Good afternoon. I'm slightly amazed. We're standing room only. I'm not going to stand up here for long. I just want to, on your behalf, offer a thank you to Dr. Kate Granger, who takes no introduction. She'll be able to do that herself. But I'm extremely grateful that she's taken the time to come to speak to us here at Burton. And I'm incredibly impressed that it's standing room only, so thank you for supporting this. Kate.
So, I guess I should start this with, hello, my name is Kate. And I'm going to tell you my story this afternoon, and why those 4 words have become very important to me over the last year or so. So, this was me. I'm 29 years old. I'm happily married to my husband Chris. I'm in my 3rd year of training as an elderly medicine registrar, looking to become a consultant in medicine for older people, my lifelong ambition. We're taking a well-deserved holiday on the Californian coastline. The weather's perfect and we're having a really good time. Apart from the fact that I've got this niggling back pain that won't go away. 2 days after that picture was taken, I was admitted to hospital in the States, extremely unwell. I had acute kidney injury, and the reason for that was that my abdomen and my pelvis were full of tumours obstructing my ureters. Bang, out of the blue, age 29, I got cancer. There'd been no warning, no real symptoms before this just occurred out of the blue. So I was patched up in the States. They popped in some stents into my ureters to get my kidneys working again, and home I came to pursue my further diagnosis with the NHS. So I then underwent an awful lot of invasive procedures and investigations. I ended up with bilateral nephrostomies. And after about 3 weeks, I finally got a histological diagnosis of a desmoplastic small round cell tumour, which is a very rare, very aggressive type of sarcoma. I'd never heard of it. It had unfortunately spread to my bones and my liver, so I was in an incurable palliative situation. There then followed 5 rounds of intensive palliative chemotherapy to try and buy me a little bit of time and improve my quality of life. That chemo was very tough. I had to go into hospital for it. I had intractable vomiting while I was having it. I developed severe bone marrow suppression afterwards with febrile neutropenia and lots of bleeding complications. I was very unwell. I lost loads of weight. I looked really sick. On New Year's Eve 2011, I made a big decision. And that big decision was to stop my chemotherapy ahead of the 8 cycles that had been proposed at the start. I made that decision because the burdens were outweighing the benefits, and I really couldn't go on living the life that I was living. Because in my mind, all I wanted to do was one thing, and that was go back to work, be normal. So 3 weeks later, after jumping through all the deanery and occupational health hoops, I got back to work on the stroke unit at Pinderfields at the time. I love looking after older people. It's what I do, it's what I've always wanted to do. And I really felt incomplete when I wasn't doing that job. What I thought I'd do this afternoon is tell you a little bit about my core values as both a patient and a clinician, and then talk through that with some examples of care that I've received in my journey. And then I'm going to tell you the story of hellomynameis and where it came from and why it's so important to me. So my first core value is communication. It's what I do as a clinician. I guess as an elderly medicine physician, it's our special skill. We can't do endoscopies or operations, but we can talk to people. And talking through end-of-life care, doing advanced care planning, balancing risks and benefits of treatments in the face of very little evidence is what we do day in, day out. So communication was really important to me as a doctor before I became ill, but it's become super important to me now I am ill, because I've received some communication that's not been as good as it should have been, and that's caused me harm. So I want you to try and put yourself in my position. I'm in a side room in hospital. I think I've got cancer confined to my abdomen. I'm expecting to have an operation and probably some chemotherapy afterwards. I'm thinking I might get cured. I'm in pain and I'm alone. And a junior doctor comes to talk to me about the MRI scan that I'd had the previous day. I never met him. He came into my room, he did introduce himself. He sat in the chair beside my bed and looked away from me and kind of out of the blue blurted, "I'm afraid your cancer's spread." He then really couldn't leave the room quick enough and I never saw him again. He didn't tell the nursing staff what he'd told me, and I was left in a huge distress with nobody to support me. That is not how I would want bad news to be broken to me. That is not how I would break bad news as a clinician. Probably wasn't his fault. Probably wasn't supported by his senior staff. I didn't really see the consultant who was looking after me during that episode of care. Contrast that with a much more positive experience. When my consultant oncologist told me my final diagnosis, he was so gentle. He sat on my bed, he held my hand, and he told me so gently that it was a worst case scenario. He then sat in silence to let me take in what was going on and let me cry. That, although probably more devastating news, was a much less distressing episode of care. So communication really does matter. It's not something that we should band around. When you break bad news to somebody, they have to live that story for the rest of their lives. We just go home and that's it. My second core value is that the little things really do matter, and they can make the difference between good care and not so good care. When I say the little things, I mean somebody holding your hand, like Dr. Stark did that day. I mean somebody sitting down next to you and not looming over you when you're in a vulnerable position in a hospital bed. I mean somebody being quiet so that you can, and giving you that extra moment so that you can express your fears and anxieties. I mean somebody introducing themselves. Those are little things that we can all do. We can all change our behaviours to be more empathic. It's easy. They take a little bit more time, they don't cost any money, but they do improve our experience as a patient. We feel more cared for, more looked after. I was in hospital a few months ago and I suffer from quite bad nighttime pain from the cancer in my pelvis. And at home I would normally take some Oxynorm, put my heat pack on and watch telly. But in hospital it's more difficult to do that, and I've got a fear of the call buzzer. I hate pressing it and asking for help. It's a fierce, independent spirit that I've got. But I got myself into a right state with my pain, so I did end up pressing my call buzzer. And the nurse who came to me was so kind. She got me oxynorm straight away, she made me a heat pack, and she sat with me until my pain had gone away. The little things, they really do matter. A few months ago, I was very sick with a really serious infection. I'd got to second line antibiotics in the febrile neutropenia protocol. I was hypertensive and my temperature just wouldn't come down despite everything that was being done. I'd just had surgery and my surgical wounds were breaking open. It was just horrible. I was so ill. And the consultant oncologist had to come in and see me on the Saturday evening because I'd been so ill. And despite everything that he did, including, talking to all the radiologists and the urologists and the microbiologists and changing all my treatment round and everything, one thing that I remember from that evening is that he knelt down beside my bed, put his hand gently on my arm and told me that I was going to be okay. That little thing, I remember that. It made a difference and I felt cared for. My third core value is person-centred care. Again, that's a phrase that's bandied around the NHS, and I'm not sure we ever stop and really think about what it means. I had an episode of febrile neutropenia where I was admitted to hospital. I was put on standard protocol, tazocin, was given some IV fluids, reviewed by a consultant and moved to another ward. When the nurse came to give me my antibiotics at lunchtime on this new ward, instead of tazocin, she was giving me meropenem. The first thing that went through my mind was, oh dear, she got the wrong drug chart. Then I thought, oh, somebody made a prescribing error and written meropenem up on my chart when they meant somebody else's chart. The third, more worrying thought was, oh my God, they've got the domestos out, I must have grown something really horrible. That was the reality. Looking back through my medical notes, the consultant oncologist had been very diligent and reviewed all my microbiology that had been previously. He found that I'd grown a multi-resistant E. coli in my urine a couple of weeks before. He'd asked a junior doctor on call to phone the microbiologist and ask for some advice. They'd given the advice that I should be put on meropenem. The junior doctor had been very diligent and written all that up. I received safe care that day, but it forgot one thing, and that was me. If you could write in big bold letters across my medical notes, Kate wants to know everything, I think it would be appropriate. But that was a serious change in my treatment, and it was never communicated to me. That made me upset. For my first house job, I worked in Dewsbury Hospital, and I worked for a very wise physician called Dr. Kemp, who was coming towards the end of his career. He was a diabetologist and had been a physician for donkey's years. And he told me one day, Kate, being a good physician is about painting the picture. It's not about ticking protocols and following ticking boxes. It's about painting the picture and finding out about your patient, filling in a little bit of that painting every day until you get a masterpiece. I guess that's what William Osler was saying all those years ago as well. And that leads me on to my fourth key value, which is see me, not just my disease. Person first, disease second. I was once referred to within earshot as being that girl with DSRCT by a consultant. Within one sentence, at a time when I'd been mutilated and felt vulnerable by my disease, I was just reduced to a rare cancer. That's not what I needed to hear at that time, because I'd lost my identity anyway. I'd lost my profession at that time. I'd lost a lot of my family life because of what had happened to me. There's a lot more to me than just a rare cancer, and I don't want to be identified by it, and I want to be recognised as a person first. I sent this tweet when I was in hospital. I was on a urology ward, and everyone kept referring to me as bed 7. Seriously, I didn't have a name. It was awful. It was bed 7, would you like a drink? So I normally use my whole 140 character word limit when I send a tweet, but this is an angry tweet because it's short. Yeah, we all have names. People first, disease second. This is a hospital selfie. And I took it after I was being sleep deprived for three days, and I felt like I was being tortured. I'd come into hospital with febrile neutropenia. I'd been very unwell, and I'd been through the sequence of 2 a.m. OBS, 4 a.m. change your fluids, 6 a.m. OBS again, just as you're getting back to sleep, antibiotics, 8 o'clock, would you like a drink, 10 o'clock, would you like to change your bed, 11 o'clock, can I clean your room? And I'd been through this sequence for 3 days, and I was just getting really, really tired, and all I wanted to do was sleep. And my nurse was very kind. She'd recognised that I was tired and just let me sleep, until the phlebotomist woke me up for the unnecessary blood tests that had already been taken from my portacath. Then the healthcare assistant came to change my bed. Could that not wait a little bit? Then the straw that broke the camel's back was the cleaner literally yelling at me until I woke up so that he could come in and clean my room. Felt like I wanted a do not disturb sign on my door. But sometimes it made me reflect on, do we run wards for our own convenience, or do we think about our patients' needs? I'm going to move on now and tell you the story of hellomynameis. So, in August last year, I had an operation to replace the stents that drained my kidneys. Necessary surgery that was uncomplicated, and I went home after my 4-hourly OBS were done. Unfortunately, 36 hours later, I developed a high fever, I was very tachycardic, and I felt really unwell. So we ended up in the emergency department. And there, after being triaged by a nurse that I'd worked with and knew quite well, things started to slide a little bit. I was cannulated by someone. I'm not sure whether they were a clinical support worker, a healthcare assistant, I'm not sure, and she had no name. I was clapped in by a surgical doctor who introduced himself as one of the doctors. He seemed a little bit put out that I wanted to know what his name was and what grade of doctor he was. I then had some antibiotics administered to me by a nurse who had no name, and more importantly, she didn't check my name or my allergy status, and I didn't have a name band at this point. Then I met Brian, and Brian was a porter. Brian was to take me from the emergency department to the ward. He recognised when I stood up that I was in pain. He got me an extra pillow and an extra blanket to make sure that I was comfortable. He took extra care pushing the trolley over the bumps in the corridors on the way to the ward. All the time he was talking to me and my husband in a reassuring manner. Those little things, they really do matter. So then we got to the ward, and there followed a week-long admission for antibiotics and monitoring. And it became apparent that this lack of introductions wasn't just a problem in the emergency department, it seemed to permeate through the surgical department as well. But when somebody did introduce themselves, it made such a difference to me. It made me feel human again. It made me feel like a person, and that I was connecting with the people that were looking after me. If a nurse came into the bay and introduced herself in the morning, I knew who to ask for. I couldn't just call a nurse, I knew what her name was. And that made a big difference to me. Made a big difference in relieving anxiety. Ooh. So I was talking to my husband about this one visiting time. My husband works for a big supermarket in quite a high-powered management position. And so he's a very practical, logistical kind of person. And he said to me, Kate, will you just stop whinging and do something? So the result of that conversation was #hellomynameis. We decided that we'd use my already significant influence on social media to try and see whether introductions were a problem elsewhere and whether we could inspire everyone in healthcare to recognise the importance of an introduction. I think it's much more about common courtesy. I don't think it's just that ticking the box, oh yeah, I've said what my name is. I think it's got a lot to do with the balance of power. As the patient, you're down here, and as the healthcare professional or healthcare staff, you're up here in the power state. And that's all because of information. Healthcare professionals know a lot about you, and you know next to nothing about them. But giving your name helps to redress that power imbalance. I also think it's about human connection, about building trust, about building that all-important rapport that we all want to aspire to when we're dealing with our patients. So, I wrote a blog about the experiences that I had and invited people to pledge their support for the campaign. I also started tweeting quite frequently using the hashtag and asking other people to do the same. I have a friend who's a graphic designer who gave me a visual identity and a logo for the campaign. We developed a website with my IT geek brother. And soon people started to listen. I got a call from the BMJ editor saying, please can you write for us? And then it all started to spread across the NHS. The campaign seemed to strike a chord with people. There were lanyards, name badges, selfie campaigns, posters, screensavers, competitions, all sorts of things going on across health and social care, and even spreading out into other sectors that you wouldn't perhaps think of as needing this kind of input, like the police and teaching. The government got hold of it. If you turn to page 36 of the government's response to the Francis inquiry, you'll find a box all about hellomynameis. Jeremy Hunt talked about it in a high-profile speech he gave quite recently. He didn't ask my permission to use my idea though. I took the idea to the International Forum on Quality and Safety in Healthcare in Paris, where I spoke and had a poster, and I also indoctrinated one of my healthcare heroes, Don Berwick. I've been asked to talk at some of the most high-profile healthcare conferences, including the NHS Confederation just a couple of weeks ago. And this is making significant impact on social media. I don't know how many people in the audience do tweet, but it's making a huge volume of impressions, and people are tweeting all the time. It's about 3 tweets an hour about hellomynameis. And I'm asked to come and do things like today all the time. In fact, I'm trying to cut myself into about 15 to try and be in all the different places that people are asking me to go to. But why am I spending my precious final months of life trying to push this forward? It's because I love the NHS, and I think we can all do our jobs a little bit better. But sometimes we just need to stop and think about why we do our jobs. And we do our jobs to look after patients. And we need to put patients at the centre of everything we do. And I guess hellomynameis is the start of providing that truly compassionate care. I've got a bucket list. And on my bucket list, I got to meet Michelle Reed Jr. and dine at Le Gavroche. So I just thought I'd end on that positive note. But no talk of mine would be complete without just a little plug for my books. I've written 2 books about my experiences of living with cancer and what it's like on the other side of the fence. All the proceeds go to the Yorkshire Cancer Centre. Together with my husband, we've raised about £125,000 for them so far. But I'd like to make that £250,000 before I die. Thank you for listening.